If not, I will move on to introduce Dr. Michael Watson. I don't think he needs much introduction. He is certified clinical cytogeneticist, but I think we know more about Mike as an executive director of American College of Medical Genetics and the American College of Medical Genetics Foundation. But today he's here to share with us as a director or the person who's leading the grant for National Coordinating Center, and which are helping coordinate all these regional collaboratives. So without any further ado, please join me in welcoming Mike.
All right, Adria is in charge of technology. Just hope we're not going to really get feedback. No, we're going to get to listen to me breathe. How's that, better? All right. Oh, wait a minute, way down. I'll stick with the microphone here. Okay. All right, well, thank you. This is an early warning for all of you coming speakers. All right, well, thanks. It's always nice to get back to the Southeast, having been born in Alabama and passed through transiently as an infant. Might get back here often nowadays. So I'm going to zip through this. We have a lot going on at the Coordinating Center. Some of it obviously is going to overlap with things that Ronnie has already spoken about, because we very much have similar charges in the work we do. So you know the system, 7 regions, sort of distributed by equality of numbers of births across the regions was the method behind the madness of how they were formed. The NCC itself is a cooperative agreement. One thing that's unique about our cooperative agreement for yours, Ronnie alluded to the fact that they're in the 3rd year of 5, we're in the 3rd year of 3. So we begin our competitive renewal come springtime. And we'll be starting to move forward on new projects and things in the upcoming year as we prepare to close out what we've already started and move into some new areas, and I'll allude to a few of those. We work closely with the Genetic Alliance. Their National Genetics Education and Consumer Network works through the National Coordinating Center for the Regional Collaboratives, and they have become increasingly aligned with all the regional activities and NCC activities to give us a much stronger consumer representation in the Regional Collaboratives program. And our broad charge is very much the same as yours, except we facilitate a lot of what you do, and when things move to a national level in education and other things, we get much more directly involved. So I'm going to take you through a few things. Really, one of the biggest changes that came with our competitive renewal this past time was the need to really get a much more robust evaluation program. As much as we all like coming together and meeting with each other at these meetings, that is not the measure of success in the eyes of the government. So we now are very much pressed to demonstrate that we are doing things of value, that we're making an impact, and that's very much what the evaluation program's about. And you know, it is in its really the very first round of really robust data collection, which is setting our baselines, and that's not done for fun nor therapy. You set the baseline so that you can actually know what it is, where you're starting, and what it is you need to improve on. And that'll be really what we focus on a lot over the next year, is where do we really find ways of improving on some of the measures that we've already begun to collect data on. So I'll talk a lot on the evaluation program, since everybody participates. I'll talk some on some of the other activities that are taking place, some of our work group activities, and then very briefly, where there are things that ACMG, the ClinGen resource, or the NBS, the Newborn Screening Translational Research Network are doing that overlap with the regional collaboratives' interests. I'll touch on those, but only very briefly, with the idea that if you're interested in them, you can talk to me at breaks and poster sessions and others about those sorts of things. So those first 3 bullets in this slide, evaluating our work and showing our impact, those are really what Michael Liu, the administrator of the Maternal and Child Health Bureau, has driven home to us many, many times in meetings. And that is, how much are we doing? How well do we do it? And the biggie is anyone else better off for the work we do? How do we measure those things that we're making an impact on the areas that are important to the activities of the NCC and the regional collaboratives? So our goals to get to some of these places are to show that the funds expended for the collaboratives are having a real measurable impact, to demonstrate the value of having a regional approach. And that is an important question that we're asked often as to, could we possibly do this with just a national center, resource center, as HRSA has for many areas? Or is there a strong reason to have a regional collaborative structure? Is there enough variability in the issues we deal with to justify that regionalization? And those are things that we need to think about as we move into this evaluation plan, and really how do we improve on it, is really making sure we're focusing on the value of that regionalization kind of strategy. And then measuring our activities in the context of both national indicators from Healthy People 2020, things that are being done through the regional collaboratives, and other forms of data or sources of data for measurement. So we have a sort of a three-tiered evaluation process. We have national evaluation that works through some of the measures that are built into the Healthy People 2020 program. We have some clusters where there are multiple regions working on a similar project. Don't you love it when your phone rings in your pocket while you're talking? Make that end quickly. So there are clusters, which are those things that are happening in more than one region around the country, and then there are local activities, and they're all important. The local activities are those incubated projects that a region thought of and is bringing up, and when attractive, many other regions begin to participate. So we have this whole chain of activities now taking place in the regional collaboratives. To look more closely at them, I won't look closer at the Healthy People 2020 because we take advantage of whatever measures are already in place in those evaluation components that we have little control over, though we are able to access the data. We are collecting data in the area of national data collection. We use the Children with Special Healthcare Needs survey, where there's questions that have been asked that are important to that survey, where we've gone out to both people who are registered in the ACMG's member directory, but also our clinic directory, which is one that is not restricted to just ACMG members. It goes out to all genetics clinics in the country, so we're able to get much broader information than we could otherwise from just our members. And we really want to have a number of questions that we're asking there. I'm not going to go into all those in detail. Do you guys make these slides, Ronnie, available to everybody after the fact? Okay, you can read the details later, but there's a lot of stuff I need to work my way through. And we've done surveys now across the regional collaboratives to find our outcome measures, the pieces of information that we want to survey and collect to establish these baselines of our activities. And are moving forward on those. Now the first year, common measures and findings, we've been looking at education and training activities. There have been webinars, there have been teleconferences, public information websites are out there and accessible and they can be measured. We can look at collaboration and the consumers and organizational engagement with other resource centers that are funded by HRSA. Access to care is one of the measures that we've been looking at. Newborn screening capacity building. As newborn screening continues to expand, we try to monitor how rapidly new conditions move into the various states, what are the impediments, and what can we do about those. Unfortunately, across multiple projects between NBSTRN and NCC and RCs, we're able to get at these in various ways. And then RC activities being highlighted as well. Findings from the most recent survey, the RCs work with about 442 different organizations across the country, and more than 4,400 providers and consumers have interacted with the RCs. There's 145 RC education and training sessions going on. They've reached more than 2,100 participants, nearly a third of whom were consumers. So these are the kind of measures that we now have baselines on, and our next goal is to figure out how do we improve on these? What are the kinds of projects we might do to enhance the activities in these areas where we now have baseline measures of where we're making an impact? There have been, I'm going to skip this one because time's flying fast. Year one activities. The NCC Genetics Professional Care Coordination and Transition Survey is one I alluded to that went out to those two directories, ACMG members and the clinical service centers across the country. We had respondents of various types you can see listed there, university hospitals, children's hospitals, private labs, the whole kit and caboodle. Multiple disciplines are involved, from primary care out to specialties. We looked very closely at the GOT transition programs. You can see that level 1 is the lowest level of measure of some of these sorts of collaborations. In fact, level 1 is sort of basic care as we're looking at transition and coordination of care. Level 1 means you're providing basic care to people. Level 2 means that you're providing responsive care. Level 3 means that you're providing productive care. And level 4 is comprehensive care. So as we look at the way the NCCRC has performed in the eyes of those providers who have responded to our survey thus far, in that area of level 1 and 2, which is basic, and I always forget these. Yeah, you can't see them. Level 3 and 4 is productive and coordinated care. In level 1 and 2, communication with other providers, about 59% of folks have been maintaining that kind of interaction and coordination of care. With families, about 68% of the providers. Care coordination with other providers, about 65% of the respondents were active in that, had activity in that area, and preparing their patients for transition to adult care, about 84%. For these higher levels of coordination of care, levels 2 and 3, about 80% had been involved in care coordination support, direct support to the families in coordinating care, and communication. So if you look across the bottom at those histograms, level 1 is blue out to the purple, which is those level 4 of care coordination. And you can see that we're pretty well in the middle, and we have plenty of room for improvement in our projects in a number of different areas, but I don't have time to go into that in really grim detail. As a coordinating center, we're obviously heavily involved in communication. And we use the NCC collaborator that goes out to all the regional collaboratives and also goes out to other resource centers and many of those other organizations that folks responded to. If you know of groups that you're working with who you would like to get that newsletter, that don't get it now, get in touch with Alicia Keene with us, who can make it available through email to any of the groups with whom you're working. Gives them a good understanding of the many things that are going on in the regional collaborative program. We have conference calls periodically. The PIs meet, or the project directors have a call once every month. We have our annual meeting, and we have many meetings with our staff, our project officers, and other leadership at HRSA in the Genetic Service Branch at MCHB. We do some other things at the national level. We use the FACMG meeting as a venue for the community conversations. It's taken place now at several meetings over, I think, the last probably 3 to 4 years, and they tend to get pretty decent reviews from the people that attend them. Somewhat variable as to the number that attend, usually based on the location of the room we get and how relatively close it is to where the main meeting is, but it's always been well attended and well reviewed. We have a consumer leaders program that's taken place since 2012, brings together advocate leaders from the regional collaboratives. Genetic counseling student mentors participate so that those consumers who go to various sessions at the meeting have a place they can go to ask people questions about things they heard at the scientific sessions. So it gives them a good bridge between the detailed science that's often being presented and their level of understanding, with people in between who can help them appreciate what it means for the kind of work that they're doing. Year 2 activities, we're right now in the process of updating the act sheets. They're constantly under revision as things change in our field, but more recently are adding a whole suite of act sheets that are related to the incidental findings that can be found in genome sequencing. Very much the same principle. In newborn screening, the concept was that most pediatricians had never seen one of these patients, and they need some guidance to work the system to understand what that patient was going to have to go through for diagnosis, confirmation, and if confirmed, what the disease might be about. And it really tremendously enabled their first discussions with the families about the fact that their child is screened positive. And I think the pediatricians valued that more than anything else, was the solid sort of ground it built for them in the interactions with their patients around one of these really rare settings that they're dealing with. This is now available as an app. David Flannery, ACMG's new medical director, has some flyers in the back there. If you want to find that app and make it available to others, it can be downloaded to your various devices. We're working a lot in ACA implementation. This was a very high priority for a number of HHS agencies, and Michael Liu at the Maternal and Child Health Bureau. We got a supplement to address how well genetics is integrated into the ACA. And frankly, the ACA has tremendous advantages in that it includes prevention, something that CMS can only do in a screening environment when mandated by Congress. But ACA begins to open that up a bit, and we have opportunities to really better define how genetics and disease prevention can fit into healthcare. So we're spending a lot of time on that. We're doing analyses right now of 3 model conditions, sickle cell, Fragile X, and PKU. In order to just get a general understanding of the total framework, databases we need to go to and such to identify the data that relates to the questions we're asking of ACA, just around those 3 model conditions. And after we get that done, we can then frame a model form on which we can then begin to look much more broadly at other conditions. And this is overseen by the ACA, NCC's ACA implementation work group that involves folks from all the regional collaboratives. We're doing a lot of work in building partnership. You'll hear later, I think this afternoon, about the LEN program. We're actually going to be meeting again with the LEN program folks at the NCC annual meeting this year. We did for the first time last year. It went well, and both sides thought it was valuable, and we're going to continue that. We have a collaboration webinar that took place recently, and the joint meeting again in November in DC. The work groups, we have a medical home work group, and things are moving, so I'm going to gloss over a fair bit of this now. It's not dissimilar from what Ronnie talked about in your various work groups, because we're all under similar mandates and focusing on similar areas. So our medical home work group is very active. Chuck Norland has been leading it. We have a telegenetics work group that is now transitioned from Hans Anderson over to Sylvia Mann. And they are increasingly active and now assessing some data from a recent survey of what's going on really with the use of telegenetic services in the country. Transition activities are getting busy. We've been sort of back and forth as to whether transition fits in the regional collaboratives or not. It seems to be firmly embedded now, and we're providing support for a for a transition work group. And now we have a family history work group working as well. A long-term follow-up work group. This is actually something that ends up bridging between the NBS-TRN, where we're able to build resources and infrastructure, and the NCC. While investigators from the NIH side are interested in clinical histories of disease, public health departments are interested in utilization of healthcare services. And many of our data points align with those kinds of questions that public health has a primary interest in. So we're now working closely with a number of states to try to see how we can adapt our tools to those kinds of uses. And I've already told you about the evaluation program. ACMG is dealing with a number of issues related of related interest. Right now, I'd say the number one question everybody has is around billing and reimbursement, with the recent changes that have taken place from CMS and by the Medicare carriers that has then translated into Medicaid carriers. And frankly, it's as big a mess as I've seen in a long time. I told them when I last met with them at CMS that, I don't understand why they decided to play 52-card pickup with genetics, but basically they want us to revisit utility. No longer does diagnosis have utility, and no longer does changing how you manage a patient based on a diagnosis have utility and justify reimbursement. They want to know that all those two things together change the outcome of the patient in some way to justify having spent money on them in the first place. So we really have a tremendous challenge, given that we deal with rare diseases, and we just can't generate the robust statistical power in our data that you can in the things they're used to dealing with. We're working in the area of physician productivity and benchmarking, and David Flannery can talk to anybody about that that's interested. We're looking at some additional data sources to really help us inform how much work, RVU type work, is required for the kind of patients that we see. We have an incidental findings maintenance work group as well now working on the genomic side. NBSTRN is in the first year of its 5-year renewal that just took place. We're preparing for that increase in NICHD funding of pilots. The first pilot is now in competition to pilot Pompe disease. We did SCID a year or two ago and have a paper that is accepted by JAMA about a week or two ago on the results of that SCID pilot study. NICHD is going to be funding additional pilots in the years coming. Pompe is only the very first, but there will be a much more open sort of contract being developed that will allow the advisory committee and others to come together and decide what's the next target for funding of these pilot studies. So we think we've got a sort of a funding cycle developing to be able to run multi-state, much better organized pilots than we've had previously. We work with our other grantees that are already participating, and now we have the newborn screening and sequencing grantees that we're working about, and Olaf may talk a little bit about some of that kind of work when he speaks later in the meeting. ClinGen's a new project. It's really one that I'm one of the co-PIs on, but I think I'm not going to talk much about it because I'm near the end, but the University of North Carolina is who ACMG and Geisinger are partnered with, and as that begins to get more robust data, it may be something that you might all want to hear about and invite somebody from UNC to comment on, because it is a project to curate the clinical curation of the variant data, what all the variation in the human genome actually means clinically. As a public database, it's being considered a pre-competitive tool. We're capturing data from far and wide, have partnerships across the world really, beginning the BRCA challenge now, and looking at sickle cell in developing countries, and really trying to take a lot of the work we've been doing and get it out there more broadly. I'm not going to go through the grim details of ClinGen, except to say that it is incredibly active and busy right now. And on that, I can take questions about regional collaborative activities. Hans. Microphone? I'll let you wear this headset.
We're grateful for your work on this reimbursement issue for molecular diagnostics. And it's really difficult for us to know how to help you. You've sort of been the point person, I think, for our field with CMS. And do you see next steps, and can you think of things that we as a region or individually can do to solve the problem of lack of understanding that establishing a diagnosis does lead to better care? A diagnosis does lead to better care, and how do we have to demonstrate that in some fashion by having people who are not diagnosed and comparing them to those who are?
That may be. I think they want to see the impact on outcome, and really we may have it locally, but we've had such poor data sharing sort of systems available to us that it's hard to aggregate that data from multiple groups that see similar patients. I think the flip side of that question is one that I know is part of a number of research projects that are ongoing right now, and that is, what is the cost of the diagnostic odyssey that the families go through? Because in the absence of a diagnosis, many, many people continue down through the medical system trying to find that diagnosis. And I suspect that from a cost perspective, one of the greatest utilities that we may see is the incredible expense when one doesn't know the diagnosis and what it costs families both personally and financially to get a diagnosis, to see whether or not there is actually a treatable condition in their family member or not. This is working on the two fronts. The somatic side is pretty active. We operate much more on the germline side, and that's Medicaid. And we're setting up a network of people across the country in every state that can deal with their Medicaid departments. David Flannery's been very active in that. I'm grateful that I've got a medical director with a strong understanding of the finances of service delivery. So you can talk to David about that as well. We're working with other groups and putting things together on that front. Thank you.